It will start recording now. You can start. Okay, you can start.
Okay, guys. I will restrict the discussion for today to only bone and joint tuberculosis, right? Okay,
Okay, sir.
there are frequently good number of questions being asked on this topic. It is skeletal tuberculosis for that matter. Your medical management would be anyway covered in the medicine guy, Dr. Umesh. Okay. Okay, most common site for tuberculosis, musculoskeletal tuberculosis in the body is spine. Please remember this. Most common site for skeletal tuberculosis is spine. Okay, the order of affection of the bone and joint is first is spine, then comes your hip, and then comes the knee. Okay, okay, first is spine, then hip, then knee. Again, in the knee, in the hip, most common, as I said, in the spine. In the spine, most common is lower thoracic region. The point. Hello? Hello, am I
Yes, sir.
audible?
Yes, sir. Yes, sir. Yes.
Listen, the points what I'm stressing is basically out of the MCQs of the previous questions. Please remember, most common site of musculoskeletal tuberculosis is spine, then followed by hip, and then knee. In the spine, which is the most common region affected is
Thoracic.
lower thoracic, and then comes lumbar, then comes upper thoracic, cervical, and last is sacral. It's easy to remember. Okay, so you should look for the choices available in the MCQs. Most common, they would be mentioning lower thoracic in the form of D7, D9. D6 and 12 is lower thoracic, D6 and above is upper thoracic. So they might mention dorsal-lumbar region. So depending upon other choices, you should read the choices of the question very, very, very carefully. I can't stress anymore. So the most common is lower thoracic. So depending upon the choices available, they can sometimes say dorsal-lumbar. Okay, so
Yes, sir.
in the spine, what is the pathophysiology of the affection of tuberculosis? For that, I would briefly touch upon the anatomy of the normal vertebra. Okay,
Yes, sir.
this is the body, this is the foramen. Okay, this is a superior pedicle process, this is the inferior pedicle process. Spinous, this is the lamina, this is the spinous process. Okay, this
Yes.
is very, very important. Some amount of embryology, some amount of anatomy, I will explain, then you can understand why this particular pathophysiology of tuberculosis spine is typical of this. So this is about the anatomy of a vertebra. Here is your intervertebral disc. So again, in the spine, for that matter, what is the common type of tuberculosis? There are 4 types. Please go through this slide very, very carefully. Paradiscal, central, anterior, and posterior elements.
Paradiscal is more common.
Paradiscal is more common. Yes, very good. But these are some radiographs I will show. So you will remember. This schematic diagram you easily tend to forget. Okay. Paradiscal is, it is self-explanatory. Around the disc. Around the disc. Okay. Central is central part of the vertebral body. Okay. Anterior is anterior part of the vertebral body. Posterior, of course, and whatever is posterior. So very simple. You talk with respect to vertebral body only. Most common is paradiscal, then comes your central, anterior, and posterior. Okay?
Yes, sir.
Could you get that? So some corresponding MRI images of the affection of tuberculosis spine. Look at this picture. This is D12, this is L1. You see the disc space are very visible above, here below, and some amount below. Here you cannot see the disc at all. Two
Yes, sir.
vertebrae seems to have fused. That is because it starts on either side of the disc space, then it finally gets eroded and the fusion happens. And I'll come to that. Most common complication ending up the spine gets fused. This is causes bony ankylosis. I'll come to that later in a minute. Okay, this is one example of your paradiscal. Look at this. Look at this. This is your posterior central tuberculosis. Central. Look at the size of the body of this, here. You see the signal changes. Look at the character of the vertebra. Look at D5. This looks white because of bone marrow edema. Then comes your anterior tuberculosis. Look at this abscess. This is anterior to the body. And then comes your posterior elements, that is posterior tuberculosis. Look at this. You can easily make out the changes. Okay, this one important sign I will explain here only. This is sawtooth appearance. It looks like a saw, isn't it? Sawtooth. This is because the abscess collected anterior to the body erodes the vertebral body and spares the disc because that is resilient. So you see this sawtooth sign in anterior tuberculosis. Please remember that. Okay?
Yes, sir.
One pictorial diagram I want to present here is what most commonly they ask, what is anterolateral decompression or anterior decompression. So what are the structures removed? What are the structures removed in anterolateral decompression? Look at this transverse picture. This is your spinal canal where the cord will be there. If it is a paradiscal, the abscess will be here, somewhere here, causing the neurological deficit. So this part is lateral, anterior and posterior. So you cause this part, okay. We'll do like this. So this part is anterior, this part is posterior and lateral. So this part, gray zone, what is been shown, what is anterolateral decompression? What are the parts removed? Is part of the body, pedicle, transverse process and part of the rib. This entire thing is removed so that the cord here is decompressed. The pressure on the cord is released. Some images about tuberculosis of the hip. Tuberculosis of the hip I will explain in detail. There are different radiological types of tuberculosis. Even though if the X-ray appears normal, it could be normal type of tuberculosis. Traveling acetabulum is, actually the acetabulum is wider than your head. Traveling acetabulum or wandering acetabulum. Or it could be a dislocating type, Perthes type, protrusio, atrophic and mortar and pestle. Mortar and pestle is nothing but the old grannies what they use for the smashing of the areca, mortar and pestle to powder the hard nuts. That is one of these mortar and pestle. It's a simple English term which you can understand. So this is one such radiograph of traveling or wandering acetabulum. Actually, here the femoral head is wandering, not the acetabulum. Please remember this. Even though it is called as traveling or wandering acetabulum, it is the femoral head which wanders up and down in all directions because of the widening of the acetabulum. In tuberculosis knee, one important thing is most commonly you should know what is tripple deformity. What is triple deformity? Triple deformity is flexion, external rotation, and posterior subluxation of tibia. Okay.
Yes, sir.
This is one example of tuberculosis knee radiograph. What you can see, depending upon the stages. Early stage, what you see, the black space between the tibia and femur means some amount of movement is still available. Look at the picture here. It is completely ankylosed. This stage it can be generally the stages are synovitis, arthritis, and ankylosis. In synovitis, the joint space is very well maintained. In arthritis, it is eroded. In ankylosis, there is total disappearance of the joint space. You can very well compare. One thing you please remember, tuberculosis, if untreated or treated very late, ends up in ankylosis. Please remember, ankylosis. Ankylosis is absolute absence of movement of the joint. So ankylosis, again there can be fibrous ankylosis or bony ankylosis. This is bony ankylosis. Please remember, fibrous ankylosis is the tuberculosis of any joint goes for fibrous ankylosis. Please remember, tuberculosis of any joint ends up with fibrous ankylosis. But in the spine, it is an exception. In the spine, it goes for bony ankylosis. I'll again stress it. Any other peripheral joint, tuberculosis ends up in fibrous ankylosis. And septic arthritis causes bony ankylosis. The exception is tuberculosis spine. Tuberculosis spine causes bony ankylosis. Okay, triple deformity. There are various other causes for triple deformity. Triple deformity, please remember, flexion of the knee, posterior subluxation of the tibia, and external rotation of the tibia. There is some mnemonic given in some books also. Triple, T for tuberculosis, R for rheumatoid arthritis, I for IT band contracture, P for polio, L and E, low coagulation or hemophilia. Both L and E are for hemophilic arthropathy. Okay, these advanced stages of these disease of the knee can cause triple deformity. Triple deformity is advanced or neglected stage of tuberculosis of the knee.
Yes, sir.
Something about TB hand. Most commonly, TB hand, which affects the small long bones, we call it as. This is a classical sign of spina ventosa. Spina ventosa. Ventosa is a cavity. You know, venous suction of the venous suction delivery. Ventosa is a cavity or a chamber. So yes, you see this ballooning out of the phalanges. This is a hallmark of tuberculosis of short long bones in hand or feet. Please remember this. You can see the sausage shaped or banana shaped finger here. So before going for MCQs, why there is most common paradiscal? Please remember, in embryology, the posterior notochord. Can you hear me?
Okay. Segmental artery.
Hello? Yeah, segmental arteries. Notochord is divided into somites. One somite forms half of the vertebra on either side and half of the vertebra on either side and one disc. Okay, this is adult spine. What I am marking is a somites, and each somite is supplied by segmental vessels. So this somite eventually gives rise to the adjacent vertebra disc is formed by one somite, and hence this is supplied by one artery. So you know the commonest route of spread for tuberculosis spine is hematogenous. You have to remember this. It is either through the artery or the typical of the spine is Baxton's plexus. You must know that. You might be able to recall if you have read or you have to go and read. So the common route of spread for the tuberculosis spine is hematogenous. Okay, it is not lymphatic. So the typical characteristic of TB spine is the spread is hematogenous and it is paucibacillary. You see very less of tubercular organisms. Okay. So the paradiscal, the most common cause for paradiscal tuberculosis is the cause lies in the embryology of the spine, how the spine is developed. Okay, we'll go to some questions so that I will again explain the relevant things. Earliest radiological sign of Pott's disease. Erosion of vertebra, collapse and destruction of the vertebra, narrowing of the disc space, paraspinal soft tissue shadow. Can anybody take a guess?
Sir, narrowing of the disc space.
Narrowing of the disc space. Wait a minute. Okay, a minute. Okay, see, collapse and destruction of the vertebra is late. Erosion of vertebra again. So narrowing, I was just explaining, the erosion of vertebra is again late, collapse and destruction of vertebra is late, paraspinal soft tissue is at the time of formation of the cold abscess. The answer is 3, right?
Yes, sir.
Most common site of tuberculosis. Anybody's guess? No brainer.
Fine, sir.
Very good. First neurological sign of tuberculosis spine. Quick.
Sir, increased deep tendon reflex.
Increased deep tendon reflexes. Very good. See, one more important thing is in tuberculosis spine, it's also called as Pott's paraplegia or Pott's spine. Please remember this. I'll explain it for in a minute. This is the cord. Okay. Again, deformities I will explain first. So all tuberculosis spine need not cause a paraplegia. It need not affect the spinal cord and cause paraplegia. In the early stage, as was mentioned, it is narrowing of the disc space. Okay, before I forget, two important things. So in X-ray, if there is a normal disc space, it is metastasis. If there is a narrowing of the disc space, it is tuberculosis. You please remember this. It will be of help somewhere for you in answering some questions. So I'll come to the deformities of the spine. One vertebra, if it is collapsed, say for example, our arrangement of vertebra is like this. If there is only one level of collapse, so how it appears? Not necessarily in tuberculosis. Please remember this. If there is a prominence of one spinous process, it is knuckle. Look at your knuckle, you will know very well. If there is prominence of two spinal vertebra, it is angular kyphosis. Okay, if it is more than 2, you should feel for the spinous process in the back of the spine. If the prominence, there are already anatomically prominent vertebra. One is C7, that is by itself, name by itself is vertebra prominence. Other than that, if you see prominent vertebra, if it is only one, it is a knuckle deformity. If it is more than 2, it is angular kyphosis. If it is 2, it is angular kyphosis. If it is 3, 2 and above, it is round kyphosis. This deformity, what you see clinically, has nothing to do with the tuberculosis. It can be because of anything else. Most common knuckle deformity is because of collapse of one vertebra. If one vertebra is collapsed, you see this spinous process becomes prominent. This collapse of one single vertebra can be because of just osteoporosis or metastasis of the spine. Please remember this. In tuberculosis, generally it will be collapse of two adjacent vertebrae. So what is the common deformity what we get to is angular kyphosis. More than two vertebrae, if it is collapsed, you see in multiple wedge collapse in osteoporosis in elderly lady or elderly men. So looking at the deformity also, you can be able to come to a conclusion what is the diagnosis. So am I clear?
Yes, sir.
Okay, good. So round kyphosis is in geriatric population because of severe osteoporosis affecting multiple levels. Tuberculosis, even though they say up to 7% of tuberculosis spine are multi-centric, it is at multiple locations, but that is quite rare. Osteoporosis affects diffusely.
Yes,
Okay,
sir.
poor prognostic sign of POTS paraplegia. POTS paraplegia is nothing but paraplegia because of tuberculosis spine. Before answering this, you should know POTS paraplegia can be early, late, or delayed. Paraplegia because of tuberculosis of spine, early or late. Early, they generally say it is 2 years. It is within 2 years of onset of tuberculosis spine, if the patient develops paraplegia. Mark my words. If within 2 years of onset of tuberculosis spine, the patient develops paraplegia, it is early. Anything beyond 2 years of onset of TB spine, don't take it for onset of pain or anything. You have to diagnose. The patient will be going all around maybe 2 months, 3 months before the patient, anybody comes and diagnose it. So once diagnosed tuberculosis, within 2 years, if it develops neurological complication, not necessarily everybody, anybody for that matter, if they develop complication in the form of paraplegia, it is early. Beyond 2 years, it is late. So one more important thing I will tell here is early onset tuberculosis is because of abscess where the tuberculosis is active. It could be because of the abscess, or it could be because of the granulation tissue, or it could be because of the edema in the tight canal, or it could be because of the sequestrum. So these are all the hallmarks of acute disease. So acute disease or early onset, it is a good prognosis. These are all can be treated with ATT. But
Yes, sir.
late onset is if already the spine is like this, the spinal cord would be stretched and it becomes myelomalacic. Myelomalacia means myelo is cord, malacia is spine. I mean soft. Remember this word. Osteomalacia is softening of the bones. Myelomalacia is softening of the spinal cord. Similarly, malacia is a common word for softening of the organs, softening bones. Okay? Myelomalacia, osteomalacia, all these are derived from the common words. Okay? So prognosis is good in early, prognosis is poor in late. But there is something called as acute onset of paraplegia in the TB spine. This is because of vascular insult, sudden thrombosis of a spinal artery. Again, in this, it is the prognosis is very poor. So the poor prognostic indicator or sign of POTS paraplegia is early onset, active disease, healed lesion, or wet lesion.
Sir,
Anybody?
healed disease.
Very good. Healed lesion, healed disease. All are true of spinal tuberculosis except, okay, please go through this. Back pain, earliest symptom, dorsolumbar spine is the commonest site, exaggerated lumbar scoliosis, secondary to lung infection. You always try to, when you do not know the answer, try and answer by ruling out the choices. Secondary to lung infection, you know very well.
Yes,
It
sir.
is true,
And
isn't
lumbar
it?
is common.
Most commonly it is pulmonary, not from lymph nodes. Lymph nodes, it is less common as compared to secondary to pulmonary tuber. Yes, it is there. Back pain is the earliest symptom.
Yes, sir.
Yes,
Hard one.
any infection, inflammation, it is pain is always the first symptom.
Yes, sir.
Dorsolumbar spine is the commonest site. True or
It's
false?
correct, sir. Correct.
It is true. Correct. So what is remaining now? Exaggerated lumbar scoliosis. Please remember the spine. I'll just draw like this. Okay. This is cervical. This is thoracic. This is lumbar. This is sacral. Okay. This is the gentle outline of our spine. There is cervical lordosis. There is lumbar lordosis. Forget the sacrum and coccyx for some time. So thorax is already in a convex. It is kyphotic. Normal for thorax is kyphosis. Normal for cervical and lumbar is lordosis. So whenever there is an inflammation in the spine or infection, the paraspinal muscles go for the spasm. So what happens for whenever there is a muscle spasm? The lumbar lordosis disappears. The lumbar lordosis disappears. So if there is a spasm of the muscle, the movement is restricted. So movement is restricted means lumbar lordosis is also disappeared. Lordosis, so you please remember, lord, they walk like lord with tummy forward and the upper thorax backward. Lordosis is, you see the well-fed or the rich elite people, how they walk. That is lordosis. So earliest symptom is pain. Pain causes spasm. Spasm reduces the normal lordotic curvature. That causes disappearance of our normal lordosis. The paraspinal spasm causes loss of lumbar lordosis if it is in lumbar region. One more important thing is there is something called as coin test. Coin test. You know, if there is a if you ask the patient, that is a screening test for a tuberculosis, or most commonly tuberculosis. If you drop a coin on the floor and ask the patient to lift the coin, the patient bends the hip and the knee. He doesn't bend. He will keep the spine as much as possible. You try doing that at home, you will understand. So coin test is one of the tests for tuberculosis spine, where the patient doesn't, maximum spinal movement happen in lumbar region. Forward bending and backward bending happens in lumbar region. Thoracic region, it is only for a thoracic expansion, rib cage expansion. Again, cervical, it can be moving in lower cervical, it is both forward and lateral bending, side to side bending, and rotation in atlantoaxial joint. Will not go much into that, but that is a just brief description. Okay, all are true about POTS spine except T6 to T8.
Sir,
So
posterior
this
part
is
of the
lower
vertebra.
thoracic.
Fifth number.
Posterior part of the vertebra more commonly affected than anterior side. Very good. Okay, back pain is most common present.
Most commonly, sir, anteriorly.
Yes, the answer is fifth
Sir,
one.
yes, sir. Body is the most common part, sir. And TB spine is the anterior disease, sir.
Anterior disease, correct. So no confusion in this. Keri Sikka.
Shoulder, sir.
Please remember.
Shoulder.
Shoulder, very good. So anything Sikka means dry.
Dryness.
Sikka means dry. Caries is tuberculosis. Okay? Tuberculosis of the part where there is no synovial effusion, no granulation tissue. It is completely dry, frozen. So caries Sikka. There's nothing much to really explain, but it is more typical of tuberculosis of the shoulder. Tuberculosis of the hand, as I mentioned.
Spina ventosa.
Very good. Pott's disease carries Sikka. Okay. Tuberculosis spine, best diagnostic modality. Please remember this. Best diagnostic modality.
Am I right?
Clinical definitely no. There can be X-ray again no. MRI or CT guided biopsy. Okay.
Yes, sir.
Best diagnostic modality is MRI. You know why? Because it detects early.
Soft. Yes, sir.
See, if CT guided biopsy is the investigation to confirm the tuberculosis. Please remember this. Tuberculosis or malignancy, the confirmation is always by histopathology. The gold standard for confirmation of tuberculosis is, for that matter, biopsy only. Okay, but in spine, biopsy is always confirmatory of tuberculosis, the gold standard. But biopsy can be needle or it can be open biopsy. See, needle biopsy or open biopsy. Please remember, as far as possible, opening is to be avoided because you put so much of long incision, you remove so many elements. So wherever possible, needle biopsy is the best choice. And needle biopsy need not be blind. Needle biopsy, we have to have some image guidance or image assistance. So how that can be done? It is CT guided biopsy. Okay, you can do that in the console. Mark the needle, mark the vertebra. It is generally done transpedicular. I will explain you that. So this is a vertebra. This is the pedicle. So when the patient is lying prone, you pass a needle like this, a long needle through the pedicle under the CT guidance. So CT guided biopsy, transpedicular CT guided biopsy is the gold standard. Okay, but there can be so many things. If there is an abscess already, cold abscess coming at the hip, you can drain it and send it for cytology. TB in bone is, you can answer this. It's a no. It's no brainer. Anybody can do.
Paucivacillary and
Very good.
hematogenous.
Paucivacillary hematogenous. Very good. So apparent lengthening of lower limb is in which stage? I will come to one important discussion. Apparent lengthening of lower limb is in which stage? Apparent limb lengthening in tuberculosis hip, let's say. Probably they have forgot to mention this, but this is how the question, there's no typographical error. This is how the question had appeared. Apparent limb lengthening or lengthening of lower limb in TB hip in which stage? These are the stages of the tuberculosis of hip. Okay, it is in stage 1. I'll explain you how. Stage of tuberculosis hip in stages is 5. Stage of synovitis, stage of arthritis early, stage of late
Okay.
arthritis, complications. Okay, are you following my handwriting? I am poor in my handwriting. And stage of sequelae. Okay. So here they have mentioned only 4. Let's restrict ourselves to 4. Synovitis, early arthritis, late arthritis. Okay, what happens in early arthritis? Please remember the hip, which is like this. In early arthritis, most common
Okay.
site again in tuberculosis hip is acetabulum. Please remember this. That incidentally I could recollect. So in initial stages, there will be lot of effusion in the hip. So you please remember, if there is a effusion in hip joint, the hip goes, it has to occupy maximum volume. You have to inflate a balloon where it occupies the maximum air. So that it can accommodate maximum volume of synovial fluid in abduction, flexion, and external rotation. This they very well have mnemonic Faber,
Favor.
and then comes your Fadir. Okay, Faber is flexion, abduction, external rotation. This this is the attitude of the limb. You can do it yourself where you are sitting. You can make out flexion of the hip, abduction, external. I cannot demonstrate that. It is not much of okay. You can do it yourself and understand
Yes, sir.
flexion, abduction, and external rotation of the hip. Okay, this is in stage 1. Flexion, adduction, internal rotation, stage 2. So if there is flexion, abduction, and external rotation, the limb looks longer. That is apparently long. This is apparent lengthening. They have not mentioned about true limb length discrepancy. It is apparent length. Okay. So in stage 1 or stage of synovitis, where the attitude of the limb is in flexion, abduction, external rotation at the hip. Okay.
Yes, sir.
And in arthritis, stage of early or late arthritis, the attitude of the limb is flexion, adduction, internal rotation.
Shortening.
Okay. Here, there is a shortening. There, it is initially it is a
Less than
apparent
1.
shortening initially. Then, less than 1 centimeter, and late arthritis it is more than 1 centimeter. Flexion, adduction, internal rotation also can be seen in if there is a dislocation of the hip because of tuberculosis or because of a trauma. Will not get into that. Wandering acetabulum is seen in no, it's not a difficult question. Okay, it is in tuberculosis hip. Treatment of triple deformity. It's very important. Again, see, treatment of triple deformity of TB knee, or for that matter, anything. So what is that you want to do? Anybody take a guess. ATT is anti-tubercular treatment.
Yes, sir.
And anti-tubercular treatment is a common denominator. Okay. What else? Kindly pick up the other choices.
Sir, immobilization.
No. So this is a very important slide and a very tricky question. Here, treatment of triple deformity is ATT plus replacement. I'll tell you how. ATT, if there is a patient with a synovitis, just give ATT. he will get back all the movements because the movements are preserved. More than 75% of movements are preserved. So it is still synovitis. Our joint is not damaged, cartilage is not damaged. Just give ATT and you can get back the range of movement. So you give ATT and invariably ATT and immobilization. You know when you have to immobilize? If there is pain, you have to immobilize. And there will be pain, there is no doubt. So how do you immobilize? You put traction.
Sir.
The how do you immobilize lower limbs for that matter is either you put plaster or you put traction. Please remember that. So you force the patient to lie on the bed. So you immobilize the part. You immobilize the person if it is in tuberculosis spine. You immobilize the part. If it is upper limb, you can move with a splint hanging on his upper limb. In lower limb, you apply cast or you apply skin traction. Okay, immobilize. So ATT plus immobilization and debridement. So when it is required, if the presentation is late, movements affected is more than 50 to 75%. There is restriction of the movement. So what you do here, already there is a lot of sequestrum inside the joint. It matters both hip and knee. It could be anything for that matter. This is a very important tricky question what they have asked. So ATT is a must. Immobilization. Why debridement is essential? If there is lot of necrosis, if there is abscess, if there is sequestra, your ATT does not reach the pathological site. You have to do the debridement. Debridement increases the vascularity, hence your ATT reaches very well. You can get rid of the tuberculosis. So ATT plus immobilization plus debridement. If it is in late arthritis. Okay, so ATT plus replacement. As I said, if it is a movements are 25% movements or more than 75% movements are limited. If there is a complication, if there is a dislocation, or if there is a deformity where you do not expect to get back the movement, you do replacement. Please remember, any goal of joint pathology, any goal for that matter, joint pathology, our goal should be to get back painless, full range of movement. Okay, full range of movement. So where it is possible. So the treatment for any hip, any joint is either it could be fusion, that is arthrodesis, or replacement. Please remember this. If you encounter a case of late arthritis or advanced arthritis, what is the outcome? If you leave alone, there can be arthrodesis in malposition. So finally what we have to do, whether you have to get painless joint. One important thing, painless joint is what is our goal. So painless joint can be mobile or immobile joint. So you want a painless mobile joint, you have to do replacement. I want painless immobile or non-mobile joint, I have to do arthrodesis. Am I clear?
Yes, sir.
Am I clear? Okay. Once again, so painless joint is what I want. Painless immobile joint or mobile joint. If you ask me, I'll ask for the sky, I'll ask for the heaven. So I want painless, full range of movement, but it is not possible in every case. So painless, so we want minimum, but mobile joint wherever possible. Immobile joint, when you cannot achieve movement, you have to fuse it. So fusing all joints is not feasible. You can fuse the hip joint because it can be compensated by spine movement and the knee joint. You can fuse the knee joint also, but in Indians who want to squat on the floor for the toilet and other reasons, it is very, very difficult. They have to stretch the leg. So hip is forgiving. You can fuse it. Knee, you try and achieve full range of movement. For that matter, I beg your pardon for a minute. I have to charge. Aryan? Okay. Am I audible now?
Yes, sir.
Hello? Okay. So please remember, you have to get back painless full range of movement. So what is possible in hip? You can do total hip replacement. Or you can do girdle stone arthroplasty. I'll just draw a diagram for that. So in hip you want to do, if there is a already, I'm not talking of knee now, please remember, any late arthritis. So if there is a late arthritis where the hip is totally destroyed and the hip is in abnormal position, what you do, you remove this. Okay, so in hip there is something called as girdle stone arthroplasty. Arthroplasty is replacement. Here in girdle stone we are removing this part of the head and neck. So after girdle stone arthroplasty, hip looks something like this. Okay, so you have removed the head and neck portion and it is unstable. Here you achieve painless, mobile, you got full movement, you got painless, but it is unstable. Remember this. This is not a good option for all the cases. So wherever possible, you do total hip replacement, where you replace this with the femoral head, with a cup here and a metal ball. So entire metal ball and replacement, you can do total hip replacement. I don't know if I'm clear. One important thing is, earlier they used to do replacement after 10 years after treatment of tuberculosis. Now they are doing it within 4 to 6 weeks of tuberculosis detection if the joint is very, very badly damaged under cover of tuberculosis. You please remember one point. Which of the following is a feature of triple deformity? We discussed about the triple deformity, isn't it? Can
Yes, sir.
anybody?
Posterior subluxation.
So answer this. No. Except I think posterior subluxation. Yes. Posterior subluxation, instead of internal, it is external. There is nothing to do with the tibia. There is no recurvatum. So posterior subluxation. Okay, I think that's all I have prepared slide for today.
Sir, I have a doubt, sir.
Yeah, please.
Sir, first radiological feature of tubercular spine is loss of curvature of the spine. Right?
Yes.
But if there is no, if there is in option is not mentioned loss of curvature, then we proceed to narrowing.
If there is no option, very good. If there is no option, look for a loss of curvature. Second, you look for diffuse osteoporosis. Diffuse osteoporosis. Look for this option. If this is also not there, narrowing of your intervertebral disc.
Yes.
Okay, am I clear?
Okay, sir.
So you don't, please try to remember you should always be careful about what are the options available. Then you can, okay, sorry. Okay. Anything else? There's 5 more
Sir,
minutes I
what
can.
is just sir, I have a confusion about Babcock's triangle. What जो most common site of the femur in
Yes,
tuberculosis? Sir.
yes.
Just I want to know, sir.
This part is a Babcock's triangle. In hip, you get 2 triangles. One is Watt's triangle. Watt's triangle, has anybody heard?
No, sir.
Okay, I will explain that maybe when I cover that. You please remember Babcock's triangle is an anatomical part. This is part from the acetabulum and together they form a triangle. In Watt's triangle in osteoporosis, I will, okay. Babcock's triangle is 3 sides together. 3 sides, they form a triangle. Babcock's triangle, it forms from the acetabulum, from the hip joint, and together they form a triangle. These are commonest site of origin. Together they form a Babcock's triangle. There is no anatomical site as such. It is a triangle of common sites of origin which together form a Babcock's triangle. Okay. So in continuation, I'll explain what here there is something called as Watt's triangle. There is trabecular arrangement. Even though it doesn't cover this subject, I'll explain because we have come to close to this. Trabeculae originating from the femoral head. There are 5 trabeculae original from femoral head. They are primary trabeculae. Those originating from trochanter is secondary trabeculae. Trabeculae, you know very well. This is a fine spongy bone arranged where you can see an X-ray very clearly. Those originating from the femoral head is primary, and from the GT is secondary. Okay. So now comes the question. There are 4 types of trabeculae: primary and secondary. Primary compressile, primary tensile, secondary compressile, secondary tensile. There's no much big confusion. Please remember, it's very, very logical to remember. Primary and secondary. Okay, in each of these groups, there is compressile and tensile trabeculae. Okay, what is compressile trabeculae? If the body weight transfers like this in the direction of the trabeculae, they carry the load like this. Okay, I'll overlay with this. Okay, the entire body weight goes like this. So the load is compression. Compression is nothing but any foot pump or whatever, you are compressing the spring, you are compressing. So these are in the direction of the transfer of the weight. Similarly, from the trochanter, these are secondary. More body weight is from the femoral head, hence it is primary. Here it is secondary, less body weight. So it is in the direction of the force, compressile. If they are bending like this, tensile, you bend a scale on one side. If you bend a scale with thumb on one side and fingers on either side, on the thumb side, if you make a bow, if your string is on a compressile side, the outside is on the tensile. It is a bow like this. So this is it is trying to compress, but it is tensile. You create lot of tension at these ends. The Watt's triangle is the region. Okay, let me not explain and confuse you this. please remember that Watt's triangle is with respect to osteoporosis.
Okay, sir.
Babcock's triangle is with respect to tuberculosis of the hip.
Okay, sir.
Okay. Okay. Anything else?
No, sir.
First sign of tuberculosis spine is tenderness. Please remember, tenderness is one first typical early sign of tuberculosis spine.
Yes, sir.
Okay. Umesh, are you there?
Yes, I am here.
Hello?
Yes, I am here.
Okay.
I think if they got any doubt, they can ask. Okay.
And boys, you keep giving us feedback, huh?
Okay,
Either
sir.
positive or negative, that only helps us to improve the format of presentation. What happens in the flow, sometimes we probably in the flow get into really too many things or too much. Not sure. So you have to cut us some time, or may not be throughout the presentation. At least end of the presentation, you can probably text in the WhatsApp group any kind of improvisation. Sometimes too many things are not needed. Sometimes clarity is not there. We generally are following a format wherein we discuss briefly the text and relevant MCQs. The MCQs
Yes, sir.
might not be really exhaustive or completely all inclusive. They are nitpicked so that they are just representative. And if we go on taking text, it will be really you won't be able to apply that to solve the MCQs. We are just trying to evolve this model. I hope this works, but we are open to make or fine tune the model of presentation. I mean, the presentation in the form of solving the MCQs and relevant text.
Yes, sir.
Okay then. If there are any doubts, it is fine. Otherwise, we can communicate later. Students
You
can
can
leave.
Thank you, sir.
you can probably share the video in the WhatsApp group if required.
Yeah. We'll share it.
Thank you.
Okay. Maten Roshana? Oh, okay, they have left. It was good, yeah. ಚೆನ್ನಾಗಿತ್ತು.
ನೀವು ಫುಲ್ ಕುಂತಿದ್ದೆ ಎದ್ದು ಹೋಗಿದ್ದೆ
Hold on. I'll first stop recording.